Other ventilatory manuver positive end expiratory pressure/Peep. It is a ventilatory maneuver in which positive pressure is applied to the airway during exhalation. Normally during exhalation, airway pressure drops to near zero, and exhalation occurs passively. With Peep, exhalation remains passive, but pressure falls to a preset level, often 320 cm H2O. Lung volume during expiration and between breaths is higher than normal with Peep. This increases functional residual capacity, FRC, and often improves oxygenation with restoration of lung volume that normally remains at the end of the passive exhalation. The mechanism by which Peep increases FRC and oxygenation include increased aeration of patent alveoli, aeration of previously collapsed alveoli, and prevention of alveolar collapse throughout the respiratory cycle. Peep is titrated to the point at oxygenation improves without compromising hemodynamic. This is termed optimal Peep. Often 5 cm H2O Peep, referred to as psychology Peep, is used prophylactically to replace the glottic mechanism, help maintain normal FRC and prevent alveolar collapse. Peep improves gas exchange, vital capacity, and inspiratory force when used during weaning. In contrast, auto Peep over what is set by the healthcare practitioner. This additional Peep may result in increased WAB, barotrauma, and hemodynamic instability. Interventions to limit auto Peep include sedation and analgesia, large diameter endotracheal tube bronchodilators, short inspiratory times and decreased respiratory rates. Reducing water accumulation in the ventilator circuit by frequent emptying or use of malation in the use of heated circuit by frequent or use of heated circuits also limits auto Peep. In patients with short exhaustion times and early airway closure, example, asthma, setting Peep above auto Peep can offset auto Peep effects by splinting the airway open during exhalation and preventing air trapping. In general, the main purpose of Peep is to maintain or improve oxygenation while limiting risk of oxygen toxicity. FiO2 can often be reduced when Peep is used. Peep is generally indicated in all patients who are mechanically ventilated. Peep is used with caution in patients with increased intracranial pressure, low cardiac output, and hypovolemia. In these cases, the adverse effects of Peep may outweigh any benefits. Continuous positive airway pressure/CPAP, continuous positive airway pressure FRC, and is similar to Peep. However, the pressure of CPAP is delivered continuously during spontaneous breathing, thus preventing the patient's airway pressure from falling to zero. For example, if CPAP is 5 cm H2O, railway pressure during expiration is 5 cm H2O. During inspiration, 1 to 2 cm H2O of negative pressure is generated, thus reducing airway pressure to 3 to 4 cm. CPAP is commonly used in the treatment of obstructive sleep apnea. CPAP can be administered through a tight-fitting mask or an endotracheal or tracheal tube. CPAP increases WAB because the patient must forcefully exhale against the CPAP. Therefore, it must be used with caution in patients with myocardial compromise. Automatic tube compensation/ATC. It is an adjunct designed to overcome WAB through an artificial airway. It is currently available on many ventilators. ATC is increased during inspiration and decreased during expiration. It is said by entering the internal diameter to the patient's airway along with the desired percentage of compensation. ATC may become less effective in patients with excessive secretions and who require long-term ventilation. Bi-level positive airway pressure, in addition to O2, bi-level positive airway pressure, BiPAP, provides 2 levels of positive pressure support, higher inspiratory positive pressure and lower expiratory positive airway pressure. It is a non-invasive modality and is delivered through a tight-fitting face mark, nasal mask, or nasal pillows. The patient must be able to spontaneously breathe and cooperate with this treatment. BiPAP is used for COPD patients with heart failure and acute respiratory failure and for patients with sleep apnea. BiPAP may also be used after extubation to prevent reintubation. Patients with shock, altered mental status or increased airway secretions are not candidates for BiPAP because of the risk of aspiration and the inability to remove the mask. High frequency of oscillatory ventilation/Hfov. It involves delivering of a small VT, usually 1 to 5 ml/kg of body weight, at rapid respiratory rates, 100 to 300 breaths/minute, in an effort to recruit and maintain lung volume and reduce intrapulmonary shunting. While Hfov may be a useful mode for patients with life-threatening hypoxia, it has not improved survival or provided lung protection in patients with ARDS. Patients receiving Hfov must be sedated and may be paralyzed to suppress spontaneous respiration. All patients must receive concurrent sedation and analgesia if using a paralytic drug. Nitric oxide. No, it is a gaseous molecule that is made intramuscularly and participates in the regulation of pulmonary vascular tone. Inhibition of nitric oxide production results in pulmonary vasoconstriction, and administration of continuous inhaled nitrous oxide results in pulmonary vasodilation. Nitrous oxide may be administered through ET tube, a tracheostomy, or a face mask. Currently, nitrous oxide is used as a diagnostic screening tool for pulmonary hypertension to improve oxygenation during mechanical ventilation in this patient population. Although the use of nitrous oxide does not reduce mortality in patients with acute respiratory distress syndrome, it may be used in patients with life-threatening hypoxia. Prone positioning. It is the repositioning of a patient from a supine or lateral position to a prone, on the stomach, face down, position. This repositioning improves lung recruitment, like alveolar expansion, through various mechanisms. Gravity reverses the effect of fluid in the dependent parts of the lungs as a patient is moved from supine to prone. The heart rests on the sternum, away from the lungs, contributing to an overall uniformity of pleural pressures. The prone position is relative the same, although nurse-intensive, supportive therapy used in critically ill patients with severe ARDS to improve oxygenation. Extracorporeal membrane oxygenation/Ecmo. It is an alternative form of pulmonary support for the patient with severe respiratory failure. It is used more frequently in the pediatric and neonatal populations but is increasingly used in adults. Ecmo is a modification of cardiac bypass and involves partially removing blood from a patient with large bore catheters, infusing O2, removing CO2, and returning the blood to the patient. This intensive therapy required systemic anticoagulation and is a time-limited intervention. A skilled team of specialists, including a perfusionist, is required continuously at the bedside.